We've had the third report into failings at one hospital, a dozen or more other hospitals who have been named as having higher than expected death rates, and in about an hour's time you'll be getting a warning from the Health Secretary of complacency in the hospital sector, and that coasting, he will say, can kill patients, that mediocrity and just bumbling along is not good enough. So what are patients to make of all of this? What does it affect as their own personal experience and that kind of political discourse around the NHS have on their trust in the services? Well, on the panel, we've got Dan Wellings from Ipsos Mori, Dr. Fiona Godley from the BMJ, Roy Lilly, agent provocateur of the health blogosphere, who I know many of you will follow and read his thought-provoking comments, and Jeremy Taylor from National Voices. But I'm going to start by asking Dan Wellings to run us through what the impact has been of some of these events, some of this public discussion around the NHS on perceptions from patients and the public.
Okay, thank you, Branwen. In true Ipsos Mori style, we have used 10 charts where one would do, so I'm going to canter through this. And also, we know that not to keep you too long from Mr. Roy Lilly as well. But, okay, so where are we? The thing is, we are actually, the most interesting piece of information is actually in field work at the moment. We're polling right now on the most important issue facing Britain today, and it'll be very interesting to see what impact, if any, mid-staffs has had on that. So we have one chart which we've polled on since mid-staffs. But what I'm going to try and do is reflect on what lessons we may have learned from previous inquiries and to what extent you think this is qualitatively or quantitatively different from those. So the first thing I'm going to show you is a question we've been asking since 1983. This tracks back to 1997. And this is about the most important issue facing Britain today. And what is fairly extraordinary, and this is about where you think this might be, is where the NHS is right now and what's happened in that period. And to think again as well, tracking along, this goes up to last month. One day of field work was just after the publication of mid-staffs. We didn't see any discernible difference in that one day, but obviously there's been a news period since. This is partly because, of course, there are other things on our mind, and this is a relative question at all times, and it's the economy, although that is starting to drop. I always say this, and I think it's useful to reflect on where we were with the NHS at this point, and to remember that actually the NHS was a more significant issue of concern at one point than the economy has been during this entire period. To go back onto the NHS more specifically, again, some of you can reflect around when the results of previous inquiries of mid-staffs came out. And there is little discernible difference. And this is a key question, because the question here was asked about public confidence in the NHS. And it's important to always make that distinction between patients in certain areas. To what extent do we think that is a one-off? To what extent are we thinking about it as patients or users or taxpayers? Is the other thing. Okay. Now, in terms of satisfaction with the running of the NHS, this is the question that we ask on our tracker and have been doing for some time. During all this period of industrial action, a rather controversial health bill, and a lot of noise seemingly, actually satisfaction with the NHS has remained relatively unchanged, tracking around 70%. This goes to spring last year. But actually, we've just done a poll in December, and the results aren't public yet, but it is around the same figure as well. And again, on dissatisfaction. So it's useful, I think, when speaking to an audience like this, and we'll come on to this in a second, it's always useful to reflect on what you're hearing. And to reflect on the fact that not everyone reads the Daily Mail. You know, this is important stuff to think, where are we doing? And I think one of the frustrating things from my perspective, from a social research perspective, is that rigor and robustness that we might exercise in other areas of health data is not something we always apply to polling data or to social research data or to patient experience data, and we should do. Because one of the questions I think is always useful to think about is what are we actually measuring at any one time. Now, you may remember that the British Social Attitude Survey, which is an extraordinarily robust piece of work, random probability, and is the sort of touchstone for many of us working in this field. There was a high point of 70%, okay, in 2010, and it dropped 12 points, and there was a great deal of comment around this. And one of the extremely interesting things for us is, what are you measuring? And perhaps a little known fact around that was, what are the questions in advance of asking, are you satisfied with the NHS? Because we experience the NHS in very different ways at very different times. So there's an order effect. The question before you ask about satisfaction with the NHS is, which political party are you most affiliated to? So that's what we call priming. You are framed, you are starting to think about it in a particular way. It doesn't mean it's wrong, it doesn't mean it's right. It is what it is. And this is about patient measures. What are we measuring at any one time? So they dropped off 12 points. We tracked at similar levels. And it's because we're not asking around some of those other questions as well. And I think one of the key things for me around patient experience, around insight, and around understanding where the public is at any one time, you would never look at one source in isolation. You would never do that in any other field. So why would you do it in this one? People like to. So this was the same week. So we had the GPPS tracking at 90% satisfaction roughly with experience of your doctor, 70% on our survey and 58% on that. And the question is, which we can discuss in the session, the panel, which one's the best measure? You know, Bevan also talked about the serenity principle, that we're not always users of the NHS, but we always could be. So we always need to think about, we need to be satisfied not just as users, but as people that are paying taxes towards it. Okay, so the other thing is, this absolutely tells you about that question, about how you ask will determine what the answer is to some extent. My local NHS has provided me with a good service, yes, that's fine. My local area, yep, broadly, hospital I like, GP, trust more than any other. NHS is providing good service nationally, well, you know, not nationally, I heard about this thing that's happening in this area, etc. The government has the right policies for the NHS, no, absolutely not. And this is an important thing in terms of what we're measuring at any one time, and they are different questions. Okay, I just thought I'd show you this because there's also a question of patient expectations. And sometimes we are not measuring what people expect from the service as keenly as we are measuring whether they're satisfied. And we also don't nuance between what different people might want at different times. So this is a generational shift. Now, we did this analysis on the British Social Attitude Survey. And just to go into a bit of detail on this, sometimes we do this with members of the audience and we ask which age bracket you're in, but for diplomatic reasons I will pass over that one. But this is the pre-war generation, born before 1945. And then we've got Generation X, baby boomers, and Generation Y. Now, what you find, if you track satisfaction over time, is that there will be differences across the population. But the pre-war generation will always be more satisfied with the NHS. And this is not just about usage, because this is back to 1983. Okay? It's partly about culture and about societal. I thought someone made a very interesting point about mid-staffs yesterday. It's a societal question as well. And what we are understanding in terms of generational shift, there is a move away from collectivism. And this is partly speculation. This is the last generation that understands or has experienced any other health system within this country. And what happens, the key question is what happens as that population dies out. So you could see exactly the same service provided, but you could see satisfaction dropping off. And this is about variations in population. When we used to do place surveys, we could predict 85% accuracy what the rating would be for a certain area, knowing 5 demographic factors. And it's about variations in population. Okay, this is the same thing. Northeast is always, without fail, happier. Pass on. You know, is this about the service received or is it about expectations? And that's really key, I think, in terms of moving forward. Are we measuring what expectations are? Is the east of England and the southeast as seemingly dismal, or is it, how do you measure that objectively? You are serving different populations with different expectations, and that's really important to try and understand. Because that's also about how do you change expectations. There is an argument to say that you would have to actually lower satisfaction. A sign of lowering satisfaction could just mean that people want more. And that's a very interesting question to come to. Okay, so moving on. This is I didn't know where to put this chart in the presentation. It's complete non sequitur, but it's the only polling data we've done after mid-staffs. And I will sort of almost leave it to you to interpret. Who's to blame for mid-staffs? NHS managers 50%, government ministers 16, health regulators 11, nurses 7, doctors 3. I will pass on. You can, you can think what you think about that one. Okay, but I would just say for this audience and for audiences that I always experience working with the NHS is your proximity to something will always have a big impact on what you think is happening out there. And this is Daniel Kahneman, who always talks about this really interesting concept, which is what we see is all there is. And the question you always need to be asking is, what do I not know? So on mid-staffs, yes, for the last 2 days, you are primed to be thinking it's this, but we need to understand more generally what it is. Okay, so I would just, it's almost a kind of flag for people in the sector to think, to what extent am I receiving information, where am I receiving it from, and what impact is that having? Okay, and this is really, the point around this was around the reforms, because we did lots of conferences around the reforms, and you would expect from listening to people talking about the reforms that the country was in revolt, but no one understood them. You know, and no one was really following them, and it's an esoteric debate. And yes, people read newspapers, but they only read certain articles, and they might not read an article about PCTs moving to CCGs. People didn't know what PCTs were, they almost certainly won't know what CCGs are. And does it matter? This is the question in terms of what people want from the health system. And it's a really interesting question to think about with Jeremy and others. You know, what are our expectations of people using the system? Okay. One thing that I think is extremely interesting is that our kind of pride in the NHS is seemingly unwavering. This is the highest ever recording we've seen in terms of Britain's National Health Service is one of the best in the world. It's a very leading question. Not our proudest moment, but it's a very leading question, but it does tell you something. And the thing is, the more interesting is, the more it comes under attack, the more people start to protect it. Witness Daniel Hannan. And the other thing is, when you look at this, which 2 or 3 areas, if anything, of the following main areas of public spending, this was done for the Nuffield Trust, do you think should be protected from any cuts? It's NHS, it's NHS, it's NHS. Okay? There's an extremely interesting relationship we have with the NHS. So, and again, a slightly more populist poll, which we've presented before, but which 2 or 3 of the following, if any, would you say makes you most proud to be British? Who just said Tesco? 1%, we can say that's margin of error. You know, NHS, 45, you know, nothing, 1 in 10. That would be an age thing. It's probably 18 to 24-year-olds. That's entirely reasonable. But that's extraordinary, isn't it? I mean, that is extraordinary. And there's people in the audience who've seen me present this before, but, you know, it's the whole thing of, we did a deliberative event recently, and someone said, it's in the marrow of our bones. There is something extraordinary about this institution. And I wonder, we can discuss this, to some extent, do we not expect it to be a perfect service, but we love it anyway? And we are British in that respect as well. So, a few questions for the panel, I think. What impact will mid-staffs have on perceptions, and for how long? Key. So yes, I would inevitably expect in the next issues index that we will see some jump. I will be very interested to see how prolonged, if at all, that will be, to be honest. And I was talking to Robert Francis about this yesterday, and he was saying that it's a question about answering the question, and one of the things we should be asking is, how worried are you about the service? I think that's right. You need to be asking questions in different ways, but legacy of that. Are patient expectations as high as we think, or do we just hear about those that are? Okay, and this comes down to who is kind of more vocal in an area, the vocal minority versus overall views. And another really important question, how do you actually get people to expect more? This is around behaviour change. How do you actually get people to think, I need more from that service? And finally, just to pose the question, actually, does the kind of devotion to the NHS make change much more difficult? Okay, thank you.
Dan, thank you very much indeed. I think I'm mainly just relieved, actually, that the BBC came ahead of such magnificent institutions as the WI and John Lewis and Marks and Spencer's. But a very interesting view of how people think about the NHS as a whole. This is not about people's individual experiences of their own treatment. this is not about people who are currently using or have recently experienced care. It's how they feel the NHS is doing overall as an institution. So I'm going to come first to you, Jeremy Taylor, to talk about this difference between this kind of perception that people have about how the NHS is doing very well. I thought the stuff around proximity was very interesting. People trust the services closest to them, and that diminishes as it gets further away, and how that fits with how people experience their own care.
Okay, thank you. I didn't know I was going to go first, but and I think that was a really fascinating presentation, and in a way it's a healthy reminder that there's a kind of health policy ivory tower that gets very obsessed about micro changes to the NHS. And there's a real world of people out there who are mostly not paying much attention to the policymakers and are just getting on with it. And I think for me there are some important distinctions that need to be drawn. There's a very important distinction between the public in general and patients and service users, people who are currently or have recently gone through the system. I think there's also a very important distinction between general satisfaction and people's actual experiences. I very much took to what Dan said about whatever you measure, you can't rely on any one source to give you reliable information. I think that's very live and topical because we have a policy environment that increasingly is friendly towards the notion that A, patient experience is a good thing and we need to understand it and measure it, but B, a tendency to want to default to single measures like whether or not you recommend this service to a friend or a family member. So it seems to me we actually don't know enough about the detailed experience of patients and service users and relatives. That needs to be captured and measured and acted upon in a much more detailed way. So there's a whole set of issues around doing what Lord Darcy said, which is that patient experience is one of the fundamental dimensions of quality. We don't treat it as such yet in terms of the way that we measure and try and understand and respond to it. And I think the other interesting thing is we've been talking about satisfaction and experience, but actually this session is about trust and confidence, and I think those issues are slightly different. I don't know whether you ask questions about people's confidence and trust, but I think there's some very interesting questions about whether perceived failings in the NHS have an impact on trust. I want to say a little bit about trust and confidence. Just on the question that you posed, will mid-staffs have an impact? My sense is, in terms of overall public confidence, my guess is probably not. And I think there's a I love drawing distinctions, I'm just too cerebral. I think there's a distinction between bad things that happen in a particular time and place, and Stafford Hospital is a classic example of that, and systemic deficiencies which are felt as such. So we've kind of forgotten that the NHS used to suffer from a major problem with waiting times that affected a large chunk of the population. And we've forgotten about winter flu crises and all the other things that used to really affect the system as a whole. And actually one of the great successes of the NHS over the last few years is to largely abolish those really big systemic things. I think they did affect public confidence rather more than something that can be seen as something went wrong in a particular place. I think trust and confidence is, trust for me is the currency of healthcare. And I think the question is, how do you maintain trust in a world where there is such change going on? And I think some really interesting questions about transparency. So we're all in favour of greater transparency. What transparency will do over time is make the general population aware that there are huge variations in quality. And I think there's an interesting question, what impact will that have on trust and confidence over time? My feeling is it may well have a corrosive effect unless we align greater transparency with greater accountability and action in the light of differential performance to do something about it. So it seems to me we've let the transparency genie out of the lamp, and I think that's right. But if all it does is highlight poor performance that nobody does anything about, and people know more about it than they did before, then we've got a problem. And just a very quick question, could that also drive the expectation to this generational gap that Dan was talking about, that you're going to have a more demanding cohort of patients coming through who will be interested in using what they see about variation to demand better care? I think, well, the evidence is that that's happening, but I think we also need to think about the people whose expectations are too low, who tend to be less vocal, who tend to be less on the radar of policymakers and commissioners and service providers. I don't know, because I haven't got an evidence base for this, but my suspicion is that part of the reason why there's general high levels of satisfaction in the NHS is that overall our expectations may be too low. So I think there's an interesting question. What is the right level? What is the optimum level of distrust that we should show towards the NHS?
I think that's a good point to move on.
I'm happy to come back to that one.
That's a question we can come back to. So, Roy Lilly, do you think that there is a dissonance, but perhaps between the fallout from what came out of the Stafford inquiry and actually a more constant, if we were to believe the sort of picture that Dan presented, a more constant satisfaction and belief in the NHS?
Well, look, I mean, I think this is very difficult to say, and I don't mean it in any way discourteously, but I think the Francis report is irrelevant. And I don't mean any discourtesy to its author or to the people,
the patients.
or let me finish what I'm going to say, or to the people involved. And I was with some of them a few days ago. If you were running an organisation in February 2010 and you didn't read Robert Francis' first report and you didn't get to the bit where a bloke was left on a commode for 10 hours and it didn't reduce you to tears, then you shouldn't be in the NHS. And if it didn't, if you were in any kind of managerial role or on a board, if it didn't impel you to read his 18 recommendations and change your organisation, if you waited until 3 or 4 weeks ago for another 290, you're the kind of numpty that shouldn't be running a chip shop. So, as important and significant as it is, and it's hoping, you know, it gives a sense of closure, and I mean, why did we wait for Francis 2? We knew what Francis 1 said. How stupid you have to be. And as it is now, you know, people are going to make a fortune out of conferences and all the palaver around it. You know, and I feel really sorry for Robert Francis. You know, it's turned it into like a circus. And I just think the whole thing has been dreadfully badly handled. If we didn't know what we needed to do in 2010, we shouldn't be here.
So are you saying there's now a sort of moral panic that's been
yes, of course
created by the whole
people
dialogue
are running around
this?
like headless chickens doing a response to Francis. I mean, I published our newsletter. We get into 100,000 inboxes a week. And everybody that's got a press release sends it to me. I must have had 47 responses to Francis. I just shred them. I'm not interested. What do I want to know about the society of whatever it is Bunyan people respond to Francis? It's irrelevant. It's about boards. Most boards are bad. And that's our problem. And we need to fund the front line properly.
So coming back to the patients, do you think that most of the public and patients make similar distinctions between catastrophic failings in one place and a more pragmatic approach?
No, they don't. They don't, because for the first part, and it was quite interesting what you were saying in your very elegant work, although Dan and I aren't talking because we did a survey and he trashed it as being a zombie survey.
Let's not go into that. We could be here. We could be here for a while.
You tell Dan.
I can move if you like. Roy.
We're moving on from that, Roy.
Tell Dan I'm not talking to him.
Okay. I'll tell him afterwards.
Okay.
But in the meantime,
but in his very elegant stuff, I mean, it is clear. I mean, there's the age thing. We need to pay attention to that because, you know, what happens if I take my mum to hospital? She's 93, you know, and she goes and uses the lavvy. And she comes out and she says, well, it wasn't very clean. And I said, well, let's tell somebody. She said, well, no, don't tell him, don't make a fuss, don't make a fuss. You know, they'll take it out on me. You know, if you go with the kids and the bog's filthy, they take a picture of it and stick it on Twitter. Yes! Embarrass them.
Yes.
You know, make it really difficult. And any chief executive that's not on Twitter and doesn't follow his hospital Twitter feed shouldn't be a chief executive, because they're not where it's happening. Older people, it's different. It's entirely different. And actually, I have to say, I mean, I spent all yesterday in a, quote, failing hospital. It was fabulous. I met stunningly good staff, intelligent managers, wonderful, wonderful frontline people. I met volunteers that go in there and help. Why is it failing? Because there's no bloody money. That's why it's failing. There's 3 hospitals when we can only afford 2. And that doesn't make the hospital failing. It makes us frightened of Monitor. They're terrified. The brown shirts are going to kick the shit out of them. You know, they hate it. And that's the problem. And most people's experience of healthcare is good. And that's the thing that we can't get over. The NHS, when it's good, is fabulous. And we don't have, thank God, we don't have those kind of experiences. Though having said that, and I'll shut up in a minute, I get about, on the days we publish, I can get up to 200 emails a day. I would say 30 of them come from NHS managers who have elderly people on medical wards who are treated badly. It is much worse than we think.
So Fiona, how do you get the balance right between, on the one hand, not having some kind of panic over the state of the health service, but on the other hand, recognising that even if 9 out of 10 patients are saying they get good care, 1 out of 10 is still a hell of a lot of people, you know, and how do their voices get heard?
Well, I was very struck by what we heard and very delighted, and it sort of confirmed one's view that public confidence in the NHS remains very high. But what I've taken from that is slightly a different version of what Roz just said, is that surely patients are not in a position to judge the complexity of health system. And we've been told that David Nicholson's the only person who understands how the NHS works, and we know that Andrew Lansley was the only person who understood the reforms. So how on earth patients are expected to understand the complexities of the health system? What they are in a position to judge, as has been said, is their own personal experience of healthcare. But as most people only interact with the health systems once, you know, a few major episodes in their own lives or in their families' lives, that's going to be very intermittent. So it seems to me that there ought to be, and we, those living and breathing in the health system, have to have a more of an absolute sense of what quality of care is, as opposed to something which is based on people's expectations or their views on satisfaction, which is of course influenced by what they read and their political allegiances and their generational expectations. All those things will influence their satisfaction, their confidence. But we, and those of us, which doesn't include me now, but those of you working at the front end of all of this, the sharp end, have to have a sense of what the quality should be. You know, the speed of response, where care should take place, dignity in dying, compassion, accountability, the idea of a named doctor. You know, it's one of the things I was delighted to see in Robert Francis' report. Patients need to have a doctor who is their named consultant. And the problem we have is that doctors don't know who their juniors are. So even though their name may be on the bed, they don't know who the junior is who's going to be looking after them at 2 o'clock in the morning. So the system has become fragmented, but it's an expectation, I think, and would be, in my view, an absolute rather than a relative quality measure, is that every patient knows who their doctor is when they're in hospital. We need to have value for money. We need to have boards who take responsibility, has been said, accountability. We need to have boards to whom patients and relatives can address their concerns if they have any. And we need to have boards who understand clinical care, many more, I would say, doctors and nurses on hospital boards, as well as people who have financial understanding. We need to have people who do, I think it was said earlier today, ward rounds, you know, board members who go on ward rounds. There's a whole host of things that I would set as, I mean, I don't want to sound like I understand the NHS because I don't. I would set as absolute measures of quality rather than things that are subject to a patient saying, well, I would have expected this or not. So, in answer to your question, Branwen, I think we, how we respond to the individuals who have poor care, it has to be they've got to have mechanisms for reporting it. I agree, photograph the lavatory if it's dirty. That's the word. I was trying to think of, you know, does the doctor wash his hands? Does the nurse, you know, is the nurse rude or polite or caring? All those things, they ought to be very, very easy ways for patients and their families to report those things. And then we need to have metrics which we can compare across different parts of the health system, and that's one of the challenges. We don't have metrics that are validated, but we mustn't let the perfection stop us doing what's necessary and listening to individual patients, recording their experiences, and learning as we go. So I suppose what I'm saying to close is there have to be more absolute measures of what quality of care really means, and we need to set those standards, because the patients are only interacting intermittently. I mean, when I say we, I mean people who are working in the systems should be setting those standards, testing them against patients' experiences as well, rather than waiting for patients to tell us what those standards should be.
But on one level, isn't Roy absolutely right that actually you should know these things if you're running a health service, and some of the information was there for Stafford. You know, I'm not talking about things like the mortality data, but if you look at the patient survey, there was data around whether or not people thought there were enough nurses on the ward, whether or not they felt people actually had time to look after them, and the answer was no. And
so that was a failure of I mean, we know that there were, well, to some extent where the failures were. There were individual failings at a major level in Stafford, and the board failed, and they were prioritising the wrong things, and a whole host of failures happened, and I think people should be individually accountable for that.
There's a part of what you're saying, Fiona, reminds me that I think there is a kind of slight culture of evidence from patients is not really evidence in the same way that other performance data are. It's anecdote. So I think part of the mid-staff story was those staff surveys were not taken seriously because they weren't real evidence in the same way as other things are. We have to change that. That's part of the culture change that we need.
I just, you know, it just mystifies me that I did a bit for you the other day, a hospital down in Kent somewhere or other. They've had their staff survey palaver thing, whatever that is. They've had their results and they've got worse over 3 years. And so the BBC said, well, what would you do about it? I said, well, sack the board. I mean, what else would you do? You know, Robert Francis gave us 290 recommendations. I'll give you another one. No hospital chairman should have an office. They should be peripatetic on the wards, out and about. If there's a meeting, they should share a meeting room. No chairman needs to have an office, and no chairman should have a free parking space. They should pay like the rest of us.
Don't get patients going on parking. It's one of those things
but the point I'm making is, you know, we are
enormously
creating an officer class. It's detached. It's not real. I did a survey in a big London hospital, a communications survey. We interviewed 80 members of staff, salami slice of staff, and we showed 80 members of staff 6 pictures of middle-aged men and said, which one is your chief executive? Right? 72% chose Terry Wogan.
That was who they hoped it was.
Yes.
It's hopeless. Boards are hopeless. We need to focus on the boards, and I'm sorry if there are any board members here, and I know we're live streaming it, and please don't write to me if you're on a board, so I'm sure your board is exceptional and difficult. But it's it starts at the board, doesn't it? Where else do you go? If you've got a numpty your board, and they are, a lot of them are. I mean, what have you got on most boards? You know, you've got a local sort of, I don't know, butcher made good, a Freemason, a Labour councillor, and some bloke who ran a business in 1827.
So Jeremy, is the answer to this to have, you know, whoever is on the board, a much stronger patient voice, and are we going to get anything like that in the next few years? You know, there's been a succession of organisations that are meant to facilitate patients' experience coming through the system, and they haven't succeeded.
I think we need to tackle this at all levels. So I think there should be patient leaders on boards. The Foundation Trust Governor model doesn't seem to quite work, but in principle, it is a way of bringing lay people who need training and help and support to play. And Robert Francis said this.
They're not lay, are they?
you need patients at every table where decisions are being made, and sometimes those people have to be found carefully and trained and supported to help redesign services, to help work on care pathways. You need to make it much easier for every patient to give feedback and to comment whether or not they're being asked a question, and make that really easy for them. So I think there are things that need to happen all the way through the system.
May I just be very rude and jump in there? Just very quickly. Look,
you're asking permission to be rude.
If I may,
Jeremy, say no.
If I may, it all starts with if I may, darling. If I may, look, we've got the reforms, okay? No decision about me without me and all that, right? I've still got the same GP because that's where I live. I've got no choice. He's in the CCG because that's where he is. He's got no choice. The CCG are making decisions about everything that he's got nothing to do with, and I've no idea. They're buying my healthcare. Nobody's asked me. Every decision is about me without me. Right? Let's not get carried away here, right? Nobody listens to me as a patient. I mean, they do me, but I mean, you know, people don't listen to the patient voice. They don't listen to anybody. They just kind of bulldoze their way on to try and muddle through.
But isn't this one of the things that has also come out of all the discussion around Stafford, which is, you know, concerns about a very defensive culture within the NHS, that when people do try and raise concerns, whether sort of minor ones or much more serious ones, they sometimes find it enormously difficult to get a human response.
That's because we terrify the senior managers and the boards. If you get complaints and all the rest of it, you get a ton of bricks coming down. I mean, you know, you get a monitor that turn up and count your debts, and you get CQC who turn up and count the dead.
Jeremy, it's definitely your turn to interrupt Roy. Go on.
The issue is not the number of complaints, it's what you're doing with those complaints. Are you allowing it, making it easy for people to come forward and voice their concerns? And not forcing them to make a complaint if they don't want to make a complaint. Are you dealing with the issues they raise? And what's their experience of the process? We don't measure that. You know, do people feel that they were treated really badly during the complaints process? So I'm quite glad.
They handle them badly. They're right.
I'm a bit, you know, I'm a bit sceptical about the Francis reports, you know, leading to a whole load more reviews. I'm involved in one of them for my sins. But I think there probably is a rationale in looking again at complaints, because I think complaints handling just doesn't seem to work across the system. It's perceived as adversarial and bureaucratic.
Do you think the problem is partly the word, that actually the word complaint, sometimes people don't necessarily want to complain in a formal way.
No.
They might want to just say, could I just point out to you that ward wasn't very clean?
If you run a business, right, if you run a proper business, the thing you need to know most about are complaints. And, you know, the NHS pays lip service to it, but, you know, if you run a business, you've got to know why people complain. Because if they complain and you don't fix it, they go someplace else. And you can't afford that, right? Because this is a competitive environment. You need to keep your customers. Not the same in the NHS. They complain, whatever, they've got to come back anywhere. We're the only hospital.
But many people don't complain, so you also need to find a way of getting the insight from those people who've got concerns. But a lot of people don't complain because they don't see the point, because they think nothing will change.
Yeah.
A lot of people don't complain because they fear that to do so would have adverse consequences for them or their relatives. And I'm looking at Steve Field. We've been doing some work on the NHS constitution for what seems like too long now. Now, it's interesting that you have a right to make a complaint, but you have no legal protections if you make a complaint. So being protected against adverse consequences is a commitment, a pledge, but it's not a legal right. So actually there are a number of areas where the law doesn't actually give much voice to and protection to.
The law makes it more difficult.
I'd like to see patients having whistleblower rights, as staff do.
Okay, I can see that we're running close to
292 recommendations.
Yes, the list is growing, I think, virtually by the week. Can I ask you all just briefly to sum up, starting with you, Jeremy? I mean, do you think that we're going to see inevitably what's going to be a very heated debate in the run-up to the next election, sort of a disconnect with the public in terms of what their own experience is and how they feel the sort of political and public debate is going around the NHS?
My guess is that probably the NHS will bump along below the radar of really, really important issues for the public up until the election. Then it might. So a lot will depend on actually none of the stuff we've been talking about, but the austerity challenge and how the NHS is able to manage growing demand and change the pattern of services to meet that demand more effectively. That's the big question. That's going to involve. So I think one of the things that may have an impact on wider public perceptions is reconfiguration, because there's going to have to be more of that. But history tells us it tends to be badly managed. And it was badly managed in times of plenty. It's going to be harder to manage it well in austerity, particularly if it's seen that the changes are more finance-driven than quality-driven, despite the rhetoric. And so that's going to be a real difficulty.
Roy, you touched on the number of hospitals. Do you think that push for reconfiguration is going to have an impact on patient trust?
Yes, I mean, we call it reconfiguration. It's not. We haven't got enough money. We've got to close some hospitals. I don't know why we're not honest about it. And, you know, Hunt's got himself, I mean, he's such a stupid boy. I mean, look what he said this morning in the newspaper about everybody's complacent and all this. Where's he going to go to at the time of the election? Because when the election comes, you know, they're going to say, oh, we've done this in the schools and we've done this in the prisons and then we've made the NHS better. Excuse me, Secretary of State, it's 47 headlines where you've said the NHS is no good. I mean, I don't know what they're going to do about it.
So what does that do to public trust?
Well, we'll have to, I mean, Dan is the guy to ask that because I don't know. I mean, it seems to me that it's very hard to erode public trust in the NHS because it is a much-loved institution. We all depend on it, and we've only got one National Health Service. It's not like we can, you know, switch our business around. So, I mean, that's a very complicated thing, but I would say this, that in the run-up to the election, it's going to get more difficult because after 2015, the DH are already saying it won't be 20 billion savings after, it could be 50 billion, right? And that's eye-watering. Reconfigurations, forget that, they're going to have to be closures and they're going to be quick because they will run out of money. They won't be able to keep them going. And Hunt's got nowhere to go because he can't say, we've made it better. Because he said we've made it worse.
I'm sure we'll have a riposte from the Secretary of State himself in his speech. But Fiona, don't doctors need to step up to the plate then in having this debate around how services need to change and maintaining public trust through that? Just a final thought.
I absolutely think they do, and I think many of them are and want to. I think that they aren't necessarily recruited and trained in ways that make them alert to and ready to take on systems of care. So they're very, you know, trained and ready to talk about individual interaction with patients and give their best to that. But they've got to begin to rapidly take responsibility for improving the system of care within which the patient is treated. And I think that remains a real challenge. And we do want to see, I think, more doctors as chief execs, more doctors on boards, more doctors understanding quality improvement and the incremental marginal changes that need, rather than putting a bomb under the NHS as a whole, just marginal changes. Diligence is what Atul Gawande talks about, just diligence about the small aspects of care that we can improve, and I think doctors can lead that and should.
And Dan, given what we know about the relative trust placed in doctors versus not just politicians but journalists as well, is that a recipe for satisfaction and trust to be maintained?
And pollsters, we don't do too well either, actually.
Don't you?
No.
Join the club.
Yes, I mean, look, you know, trust in doctors rarely, if ever, drops off 9 out of 10. And so that is a very precious thing to own from doctors. I think, yes, in terms of some of the things around the next couple of years, it is worth bearing in mind that when there are tipping points on these things in terms of where the public is. And when there's lots of money going into the NHS, there's a time lag between that and then seeing it in public satisfaction. And it works the other way around as well, that you will get to a stage where it is potential that you hit a tipping point, the media start to pick up on it, therefore it has capitalist stories, etc., and then it takes a lot of time to recover it again over the other end. So I think in terms of general sort of predictions about where it will be on election, I think it will be further up than it was last time. And it is worth bearing in mind through all this that it is the second most important issue that we vote on in the end.
That seems a good place to end. So high satisfaction and high importance to patients, the public and voters. Thank you very much to all of our panel.
Thank you.